then you can share your slides when we've done that. Are we recording, Amanda? We are. Okay, good. And it's just after 11, but I'll have some introductory things to say for a few minutes. So
No problem at all.
okay. Well, again, good morning and hello, everyone. My name is Jane Burke-Miller, and I'm a Senior Mental Health Training and Implementation Associate at the Center for Psychiatric Rehabilitation at Boston University, and I'll be the moderator for today's Making Sense of Employment Research webinar. The Rehabilitation Research and Training Center hosting this webinar is called Improving Employment Outcomes for Individuals with Psychiatric Disabilities, and it is funded by the National Institute on Disability, Independent Living, and Rehabilitation Research. The webinar does not represent the views or policies of the funding agency, and you should not assume endorsement by the federal government. The territory on which Boston University stands is that of the Wampanoag and Massachusetts people, and we honor and respect the history and current efforts of Native Indigenous communities. This webinar is being recorded so that you can access it later. Also, closed captioning has been turned on, and you can access this by clicking the button at the bottom of your screen. In case this is your first webinar with us, I'm going to introduce our speaker. They will share their research with you, and then we'll have a question and answer session at the end. If you have a question during the presentation, please post it in the Q&A or in the chat box, and I will pose them in the order we receive them at the end. If you have a technical question, please send a chat to me directly using the chat feature. Also, we would really appreciate your feedback about this webinar, so we'll be posting a survey, a very brief survey, at the end of the session. So now I would like to welcome Dr. Margarita Alegria, who is going to present her work, Key Stakeholder Perspectives on the Use of Research about Supported Employment for Racially and Ethnically Diverse Patients with Mental Illness in the United States. This webinar discusses stakeholder responses to evidence on supported employment, emphasizing the importance of tailoring programs to individual needs, which are often overlooked in current initiatives. Dr. Alegria, PhD, is the chief of the Disparities Research Unit at the Massachusetts General Hospital and the Mongan Institute, the Harry G. Leonard Jr. and Lucille F. Sear Leonard Endowed MGH Research Institute Chair, and a professor in the Department of Medicine and Psychiatry at Harvard Medical School. She is currently the PI of 4 National Institutes of Health-funded research studies. In acknowledgement of her contributions to the field, she has been widely recognized with numerous citations and awards from the American Psychiatry Association, the American Public Health Association, and the National Institute of Minority Health and Health Disparities. She is also an elected member of the National Academy of Medicine. Dr. Alegria, welcome. We are excited to hear from you.
Thank you so much for having me, and I hope to leave sufficient room because what I really think this merits is really questions from the audience. So let me go to my slides and start presenting. I hope you can see my slides. Let me go here. Let me go, I'm sorry. Let me go to the very beginning of the slides.
Yeah, we can see them.
You can see them. Okay. Let me start by saying this is work that I have done with Jenny Send-One. And actually, she's the primary author of this work. So I want to give her, you'll see her in the slides. This is something very important to, at least to me, which is that we actually disseminate the findings with community to see what community thinks about our findings and whether they find them useful or not. Let me go with presenting first that this is a team effort. I want you to see that we work in a wonderful team of people that are actually the ones that are doing the job. And we are very fortunate that they work with us on an everyday basis. They're passionate about this work. Here is Jenny Send-One. I wanted to give her the credit and all the people that work in presenting and really doing the analysis of particularly the second piece that I'll be talking about. Jenny is an investigator here at the Disparities Research Unit, and we have worked very closely on this work. Let me start by saying that, one of the biggest issues that I think is so important is that for individuals between the ages of 25 to 54 that are receiving mental health services, many of them report being either unemployed, not in the labor force, or if they're employed, not having the jobs that they would like to have. So this is an area where we could do a lot more support in terms of employment. In the article, we talked about, how when people have they suffer from mental disorders, that could really be a detraction to having work. And so supportive employment interventions and vocational rehabilitation are two mechanisms that really can make a difference in making sure that people have the support to be able to work and get, actually have opportunities for working, because sometimes they can work, but it's very hard to get accommodations in their work to make it happen. So in 2017, we don't have that very recent data. 2017, 27.4 of specialty mental health treatment facilities had a supported employment program. So you can see here, I tried getting more recent data, but unfortunately, we don't have recent data of how many supportive employment programs are more currently in 2025. However, we know that supportive employment and supported education and supported income are mechanisms to try to deal with these issues of making sure that people are able to be, to contribute to our society. And partly, we know that, for example, supportive education, there is some evidence that suggests that in terms of supportive education, it really improves. An additional 4 years of education is going to reduce diabetes by 1.3, heart disease by 2.2%, this is the prevalence, and overweight by 5%, and smoking by 12%. So really investing in social determinants like supported education has been shown to actually be very helpful in terms of the prevalence of some of these disorders going down. We see that in income, for example, since 1977, the life expectancy of male workers retiring at age 65 had risen by 6 years. But those are only for the people that are in the top of the income distribution. It's only 1.3 years more in life expectancy in the bottom half, meaning that if you look, this is data from the Robert Wood Johnson from 2013. We do get that life expectancy increase for people that are in the higher income distribution, but we don't get it for the people that are in the lower income distribution. We also know in terms of employment that unemployment may affect health in many different ways. We know that, for example, laid off employees are 54 percent more likely to have fair or poor health. So it has a big impact in terms of their health. We also compare to continuously employed. And we know that laid off workers compared to continuously employed are 83 times percent more likely to develop a stress-related condition, such as heart disease. So having those social determinants, as we talk, education, employment, and income, are really an important investment. We know at the same time that people that suffer without mental disorders live about 10 years longer than people with mental disorders. And there's more recent work that suggests that this might be not only 10 years, but 14 years. So there is an issue about, why are we not investing in more in making sure that people that suffer from mental disorders get the supports needed to make sure that they live healthy and flourishing lives. And this is something that has been thought about. So here, the question that we have in this first part of the research that I'll be presenting is, can people's mental and physical well-being be improved by making sure that we provide social services, such as supported education, supported employment, and supported income? And we looked at this at 3 levels. We looked at level 1, which is mental health status, people with common disorders versus severe disorders, and whether it makes a difference. We looked at a second level, which is race, ethnicity, Latinos, African American, Asians, and whites, whether there's a difference in what we see in terms of the outcomes. And lastly, the social service intervention type, whether it was simulated changes in education, simulated changes in employment, and simulated changes in income. Why do we use a simulation study? Why we decided to do a simulation study? And this is work that was done with my colleague. Also, I want to emphasize Bob Drake, who has been working endlessly in this area of supported employment, and you should read his work. In an ideal world, we would really compare people who receive these social services to those that receive no extra help over several years. But that's actually incredibly time consuming and actually very difficult to do. And you have then selection biases in who is actually receiving the social services versus those that don't receive it. So simulation studies are studies that you actually sort of develop to look at the impacts of many programs at once to try to decide which program is more likely to give you the information or the impact that you're looking for. And if you're going to do investments, which is the investment that is more likely to lead you to get better impacts. So this is why we simulate situations to see what happens to people when they receive those services, and this is done by a statistical technique. Let me start by talking about level 1. We looked at participants' mental health. In group A, we had people with common disorders, and in group B, we had people with severe mental health disorders, and we had 2 samples that represented this, and I'm going to explain the samples. In group A, you can see here the major diagnosis that people had. And in group B, you can see that it includes people who were receiving Social Security disability insurance and had also received a primary diagnosis or either schizophrenia or affective disorders like major depressive disorder, bipolar disorder, or psychoaffective disorders. I want to show you the level 2, which is participants' race and ethnicity. In group A, we have 3,417 adults with that comply with criteria for common mental health disorders. You can see here the distribution of the white, Black, Latino, and Asian part of the study population. And in group B, we had people with severe mental health disorders, 1,006. And you can see again there the distribution by white, Black, and Latino. In terms of supportive education, I want to explain very quickly what we mean. And these are programs that provide people that suffer from mental illness the resources and services to make sure that they achieve their educational jobs in integrated settings and not separated facilities, meaning integrated in their jobs or integrated in their education to make sure that they get the education that they're looking for. In supportive employment, we mean individual placement and support. And this is a approach where employment specialists are going to help people with mental illness who want to work, to find that work, and to actually succeed in competitive job positions. In social service simulation, which is the third level that we're going to talk about, you are trying to simulate what happens For example, in the supported education program, we sorted people by their education level and say, what if we bump people, 30% of people in each group into their next educational level? So taking into account the level of education they're in, what if we bump them 30% to higher education, 30% of them to the next higher education level? What do we see in terms of mental health? And just to let you know, we selected these percentages based on what was the evidence in the literature. So we can select those percentage bump, how many people actually are able to jump one school level more. And that's where we got that 30%. Here, in terms of income in level three, we simulated a cash assistance program by increasing household income by 10,000 or 20,000 for everyone in the study. So if we gave people $10,000, what would happen in terms of their mental health? And this is supported income cash programs that are typically can be around $10,000. In employment, we simulated a supportive employment and we bumped people 60% who said they were unemployed and moved them to an employed category. And that 60% comes from studies that Bob Drake had done on how much can we bump people once they are in supported employment, how much can we bump them forward into getting employment. We also want to say the terminology of what is significant. And a significant result that we are using here is that it has to be 95% that this is not found by chance, meaning we use a 0.05 to make sure that this is not a fluke, that this is the change, the amount of change that is significant. It has to be at least 0.05 or more in respect to the finding. And what we mean by substantial is not in terms of size. This is finding that was large and affected someone's symptoms in a meaningful way. And this might be affected them in their quality of life. So we have assessments that we do with the population, and we're looking to see whether that had the effect. So this is a paper that we published in 2017, like I said, with Bob Drake and a lot of other people, showing that increasing employment was going to be related to significant mental health outcomes. And then we are also seeing that the minority groups as well as the majority groups improved. And we also see that for people with common mental disorders and those with severe disabling disorders, it also was a benefit. Let me show you very quickly the results, and then we're going to talk about how people interpreted these findings. So we saw that for people with common mental health disorders, education had a small improvement, as you can see here. And this is important to see because you can see there by groups that for Latinos, there was no change in physical health. And for Asians, there was no change either in mental or physical health. And in the people with severe mental illness, we saw no significant change in mental or physical health. So but this might be because the sample was actually quite small to see it. In terms of income, and I'm just gonna show, we didn't find a significant effect by making a simulation with $10,000 increasing. We did find a difference when we increased supported income to $20,000, which is quite a bit, but we wanted to see whether the difference in the amount of income made a difference. And we see that for mental health, we see small improvements for people with common mental health disorders and some moderate improvements in physical health for the white population and for the African American population, but not for Latinos or for Asians, but no significant effect for changes in mental or physical health for any racial or ethnic group, partly because, again, for people with severe mental health disorders, the sample might have been too small. Lastly, we see for employment, and we see that for employment, both in group A and group B, which we see for mental health, substantial improvements for most groups except for Latinos. And for physical health, we saw small improvements in physical health for African Americans, but no change for the others. But for all the groups in the severe, for the people with severe mental health disorders in group B, we see moderate improvements, but not by race, ethnicity, but in the overall, we find moderate improvements both in mental health and in physical health. We want to show you this graphic. You can see here in the graphic that there are a lot of considerations. This were both cross-sectional studies. So one of the things we have to be careful is that the causality could go in either direction. You can imagine that treatment of mental illness symptoms can help maintain employment, and employment helps mental health. So it could be bidirectional. And we also can see that minority poverty can account for the instance where disadvantaged individuals do not benefit from increased income or education because they have a lot of other hardships that need to be taken into account. It has to be more holistic support than just income. I want to now move you to why we did this study. And let me tell you, it's very hard to get funding to disseminate results. However, we went to National Institute of Minority Health and Health Disparities and said, we spent a lot of time doing a lot of studies, but we want to hear what people say about whether any of this data is useful for them or not. And it was really fabulous to eventually, after, I think we had to submit it twice to get it funded, to really hear what people had to say with regards to their perspective on the use of research for supportive employment, particularly because this one was the one that showed the likelihood of having the biggest impact. And you'll see here in this study that we found different themes, 3 themes that I'm going to discuss. One is the perceived impact of supportive employment initiatives based on on key interviewees. The gaps in and barriers to supportive employment. People talk a lot about the barriers they had to actually be part of supported employment interventions, and also the facilitators of successful implementation. What's needed to make this programs be likely to work? And I have to say, participants from all stakeholder groups said that it was important to have diverse representation in this voices, so that we could see from different perspectives how to better improve supportive employment. That they wanted more increased availability of supportive employment in mental health intervention programs, that it was not sufficient. And then they wanted to learn more about IPS as one of the evidence-based supportive employment programs, so that they could actually ask for it and really advocate for getting an evidence-based program. Let me say about the 3 stakeholder groups that we did. And I have to say that this was one of the studies we presented to community stakeholders. We presented another one. And so we divided the time. In this presentation, I'm only doing one of the study key holder groups that was on the simulation study. And we asked community stakeholders to select which of the studies that we had done were more importance or interest to them. We had 3 stakeholder groups that we interviewed. One was people with lived experience. We had 5 participants. We had community health advocates, and this is for this, for the discussion of the participants, in-depth interviews, and focus groups. And the community health advocates, we had 8 participants, and we also had 6 health policy makers that completed the survey and information. One focus group was, you can see here, the semi-structured in-depth interviews. We also had, the first one is focus groups. These are in-depth interviews. We have 5 participants of people with lived experience, 5 advocacy groups, and then 9 state health policy makers that completed the survey. And we appreciate that they were willing to be with us and do this. I want to talk now about the sample. This is I want to tell you a little bit more about what is included in the in-depth interview guide. You know, we show them, after reviewing these recommendations and using your expert knowledge, what recommendations would you tackle first as a way to reduce these disparities? Would other people with lived experience, community health advocacy, policymakers have the will to address this as a priority? We wanted to see whether people thought, even if the data shows that this is something that might make a big difference, would they think that policymakers and others would actually make this something that worthwhile fighting for? Addressing the problem, we ask about, what are some ways you might implement the recommendations? How passionate do you feel about doing these recommendations? How would you want to be involved? We also ask about, as part of this process, we would like to hear your ideas of how you would map your work on these recommendations. What would they do? What would information they need to collect to know that they're in the right track? And also barriers. And then finally, sharing their own recommendations. In terms of the result, as I said, there are 3 main themes, and I mentioned the perceived impact, the gaps and barriers, and the facilitators of successful supportive employment. One of the things that people with lived experience mention is how important employment was to have a positive effect on their life. This is one of the things we heard over and over again. People felt that having employment really could make a huge difference in how they felt and how the respect for themselves, in terms of being respected by others because they had a job or family members. They also express the pride that is derived from holding part-time jobs. And so they really, really strongly recommended IPS. Policymakers really were describing the efficacy of these programs in really making a difference for behavioral health disorders. But policymakers thought that employment should not be considered an adjunct service of recovery, but rather a crucial one. That we really needed to make sure that people understood that this is not like a sideline, but this should be part of making sure that it's embedded in the mental health programs to provide this change. In terms of the gaps and barriers to the supportive employment programs implementation, one of the things that people with lived experience talk so much about is the difficulty in having their bosses or their supervisors do workplace accommodations, how people, when they feel depressed, might not feel of going home or wanting to work remotely. Or having medical absences that were not being considered. Even going to medical appointments was an issue. And how they thought that employers needed to know more about common behavioral health conditions and making sure that they supported the people with lived experience, establishing, trustful communications that they could explain what was happening to them. For policymakers, they really felt that there needed to be peer specialists that were benefit counselors that could say what people needed, what types of job people wanted, because more than people with lived experience, there was the issue about making sure that the job that they were offering to people could provide sufficient economic support and safety nets for people to be willing to do the work. Policymakers also raised that a lot of the problems they were seeing were not only with regards to employment, but also people having difficulty in having housing insecurity. And as a result, when you don't have housing security, it might derail from you not getting a job because you have to move around and therefore you don't have stable housing. So this was something that was mentioned about you don't only need the employment, you also need a secure housing. Both the three groups that we talked to, all of them talk about the importance of having social service programs and also these supportive employment with linguistic and cultural competence. They felt that people sometimes didn't share their linguistic or cultural competence, and that might make it very, very hard for them to really be able to engage. And this is an area that having more diversity in terms of language, race and ethnic concordance, and an understanding of the culture would be paramount. They also expressed that retention really in a lot of ways depends more on this cross-cultural engagement. And so training the peer specialists and the people that offer supportive employment is important not only for conveying the skills and the motivation, but also making sure that the way they present the program is culturally relevant to the participants. The last theme is making sure that the partnerships are super important in making supported employment. Mapping out how do you have to navigate the community resources to find the potential jobs that are aligned with your expectations and with your training. Making sure that community organizations not only offer one service, but actually help people navigate the different procedures for getting, the program, getting the job, getting the follow-up, getting additional supports that might be in terms of medical visits. So clients and providers sometimes don't know where to refer people. And as a result, people then are delayed in receiving the program. And then the other thing that was mentioned over and over again is trying to make sure that the evidence, it's evidence-based models of supportive employment, because some people are doing supportive employment, but it's really not like the IPS model. It's something that has been taken off the shelf, but the person really doesn't, the specialist doesn't really know how to offer it. So convening and facilitating the collaboration with the stakeholders that know the program is central to this. So to make sure that this works, you have to have cultural competence across the program, cultural humility, and making sure that we can combat discrimination and increase retention, because some people felt that when they went to the program, they were experiencing stigma, discrimination, and as a result, didn't want to stay in that job. That it's done through partnerships and collaborations, not only governmental partnerships, but also clinical, social, and employment partnerships that really are working together to make sure that it's successful. And an increased need to make sure that supportive employment programs receive the financial aid that they'll need. And in an end, to really do all of these programs, we need to diversify the workforce and reduce bias, both across social and professional environments, because part of the issue in not retaining people in these programs is that people feel like they do not receive the respect and the trust to feel comfortable in doing their jobs and staying in their jobs when they have ups and downs of their condition. So there's no question that these programs actually, when they have been seen, they produce, they're very cost effective for taxpayers. You know, one study found that for every dollar that taxpayers use in supportive employment, you get $1.46 backs. And another one found that mental illnesses reported, you know, people with mental illnesses that receive these programs have a return of $1.68 for every dollar spent. So they're definitely needed. But we need to have legislation and executive orders to protect supportive employment. We need to be able to use the 1115 medical waivers to support those programs, and rating of SAMHSA block grants, because many of these programs, unfortunately, require quite a bit of funding. So with that, I'm gonna stop my share and happy to answer questions.
Thank you so much. That was a lot of information. Um, So yeah, I think there's a few questions. Just kind of a preliminary one is that there was a question about understanding the simulation study and maybe its relationship to the key stakeholder study. So the specific question was, are you saying you just randomly assigned a change as a simulation to assess potential impact? You did not make an actual intervention to see what activities would keep people engaged and make a true change in their lives.
Yeah, thank you so much for that question, because it is it's sort of like three studies in one that I'm presenting. The first study is studies that actually collected data on basically people's demographics, mental health conditions, service use conditions, programs that they have done separately. And one was done with a population that was a national population. And then from those, we looked at people that have, like we were saying, moderate conditions or medium level conditions. And the other is a study that was done by Bob Drake. The first study was done by myself as a PI with a big group of people. The second study was a study that was done by Bob Drake with people that were on disability, Social Security disability. And that is the group that has people with more severe conditions. And so you have that data, and with that data, you statistically can do the second study, which is simulate. If you were giving this interventions which exist, and we looked at the percentage of people that sort of can go from one, for example, from one group of education to the next level, or with employment, or if you give income, what is the bump that you get in people, and how much income do these interventions typically give? So what we wanted to do is simulate, if you were to select, if you're a policymaker, and you have to select between doing supportive education, supported income, or supported employment, you know, which one is your best bet to invest the money without doing the study, because many of the studies are extremely costly to do, and it's very hard to randomize people to these interventions. So that's the second study. And the third study is, okay, we have this data from the second study, but what do people say? What do people that are the people with lived experience, the people that are the policymakers, and the people that are in advocacy groups, what do they say about these results? Are there any, in any sense, useful to them? And how do they think there might be other issues why we don't have these programs? And it was very useful to have this third study, because policymakers said, well, it's very difficult to get funding for supportive employment. And not everyone wants to keep it. And part of the problem, for example, was that some of the results were only results up until 6 months. And so people felt like, well, if it's only 6 months that they're going to have unemployment, that's realistically might not be enough. So we heard from policymakers, we heard from advocates that said, well, there's not sufficient supportive employment. There's also not sufficient evidence base. So that's how the 3 studies match to try to get information out and see if they're worthwhile or not.
Yeah, kind of innovative methods when you do the simulation studies, because it's kind of saying, we have data from an actual real person intervention, and so we know that for X intervention with people who are, you look like this, that, this is the outcome, and then you take that and manipulate a larger database where you don't have the intervention. It's a little complicated, but I think it's a very, methodologically, it's a great way to use data that is existing, but you don't necessarily, as you said, you can't do those large scale.
Yeah, and
Studies.
I have to say that simulations have become very, very in vogue. People do it, for example, if they're trying to figure out, to give you an idea, HIV treatments, like which one is more likely to, work better, or people with um, chronic health conditions, which of these interventions more likely. So people are using simulations as a way to try to at least select the one they're going to invest as the primary based on these types of information.
Yeah, it's very interesting. So we had another question, just more specific. When you talk about retention, is that referring to people staying employed or staying engaged in the SE program?
Yeah, people staying employed. One of the issues that people said is, sometimes because bosses or supervisors are not really trained in the mental health conditions and how they have to do accommodations and what type of accommodations they can do and whatever. It's very hard for people to then retain their employment for a longer time period, especially when people have conditions that they're might be fine for a longer time, but then might, not be as fine. And so that's the sort of issue that people talked a lot about making peer specialists or supervisors more aware of accommodations.
Yeah. I mean, this is kind of getting to the perennial question about supported employment, which is, we know it works. We have all that huge body of evidence, and yet we still have these continuing low employment rates among people with mental health conditions. And it's really access. There just isn't a lot of access. So how much, in terms of what you've seen with the disparities in outcomes, how much do you think is that sort of just universal disparities across all kinds of health and social structures, and how much may be specific to SE, supported employment?
No, I mean, I've been doing work on disparities for a long, long time, and I can tell you there's disparities. I mean, it's surprising where there are not disparities. I mean, I think the veteran services is one of the few ones that doesn't have a striking disparities, and still they do. I think that supportive employment is pretty much an area where there is, I have to say, not as much disparities as you would expect, because there is a lot of awareness about the importance of making sure that they have people with, diverse race, ethnicities. I think language is the one that's less likely that they have, but we see that there's a lot of emphasis on making sure that at least the ones that I know that were here in Massachusetts, that they actually diversify the peer specialist workforce. So that was very something that they were very aware for. I think the issue is more, like we were saying, the accessibility to get into a mental health sector that really connects you to supportive employment and making equal opportunities for all, not necessarily so.
Yeah. So what would you say are the implications for scaling up of these key stakeholder findings? Again, another perennial problem. Yeah.
I think one of the things is making them available through 1115 waivers. so that they're like, that people get paid for it to offer the services as part of the 1115 waivers, I think would be, and making sure that they're more, that instead of the brain rating that SAMHSA was doing, trying to see if they could be put into block grants in a way that it's more sustainable and not people having to struggle to try to match funding from here, from the block grant, also funding from, the federal grant, funding from the insurance company. Sometimes that, from what we heard in this, people complain a lot about how long it took them to get all of that funding braided together. And if they didn't get one, they didn't know if they could offer the program because they didn't have enough funding for the staff. So it became like very uncertain.
Yeah, the funding problem. And in terms of workforce development and diversity, I mean, that, and again, another problem is keeping people in the services workforce. How do you even go beyond that to developing more diversity?
I think we know so much now about, how to keep, everyone, people that suffer from mental illness. We know a lot more of things that we need to provide, and more support, like the importance of social support, the importance of people not being isolated, the importance of peers, the importance of good, psychotherapeutic interventions. I think we know a lot more, but as you well know, mental health suffers from being like the unwanted child of healthcare and not being given enough resources. And I mean, parity is supposed to solve that problem, but it hasn't. And unfortunately, we keep uh, saying that we're going to increase mental health services, and then, someone else comes and decides they're not going to increase. So we need more strong advocacy. There is so much evidence that, the more people have, um, that we really heal people in terms of mental health issues and physical health, but mental health is so central to people's identity, you know, being able to work, being able to produce, having good family life. So it's, to me, has always been, I've been fighting for this for a long time because I find it so central for all of us and all of our communities and families.
Just looking, here's another question. One attendee says, as someone with an SMI, the main access to supported employment offered to myself and many others is the Ticket to Work program through SSA or the Department of Rehabilitation. That's Spoke Rehab. Were those who offer services through these programs a part of this discussion? Personally, I believe these programs are very archaic, not really supportive of what individuals desire for work. What are your thoughts on addressing the federal government's approach to supported employment?
I love that question. I really appreciate you making the point. I'm a big believer in having people with lived experience create the programs that they think they need. I wonder if there could be an opportunity for doing some sort of, you know, uh, proof of concept of programs that are developed by and for people with lived experience that are, like you're saying, maybe those are too archaic because they're, from people long ago. That I'm a big believer in partnerships between the community and the research group to create a program that is co-designed by people like you, where you might know exactly what's needed and maybe be more up to date on all the things that could be done. Um, like, I mean, I was recently with an Uber driver who told me, oh, he asked me what type of work I did, and he said I really like doing this work as a person with lived experience because I'm able to um, go in and out when I don't feel well. So it's really something that works very well. Um, and so I think some programs, you might be able to create one on supportive employment I would say in comparison, in collaboration with people that do this type of work, someone like Kim Muser or Corey that do this work, and also make sure that it brings what you think is needed. I would love to hear what you think is missing in those archaic programs.
Yeah, thank you. Any other questions? I'm seeing popping up here. This has been a great discussion. Anybody have any other questions for our speaker? I'm not seeing anything at the moment. So I do want to thank you, Dr. Alegria, for sharing your work with us. If there are any more questions, you can type them in the chat or in the Q&A. If there aren't any, I'd like to thank everyone for taking time out of your day to participate. I especially want to thank our speaker for her work in presenting today. As a reminder, a video of this presentation will be posted online at the Center for Psychiatric Rehabilitation website in case you'd like to access it later or share it. In the meantime, when you do exit the webinar, you'll see a very brief survey, and if you could just take a moment to provide us with some feedback, that would be very helpful. This is an ongoing series, so we will be scheduling more webinars in 2025, which you'll hear about in your email. And I think we have reached the end of the questions.
Thank you so much for giving me the time to present this work. And I wish for the person that mentioned that the programs are archaic, I mean, I think this is an opportunity to actually make sure that people work with advocacy group, policymakers, and researchers to do partnerships to do the programs that you think you need and that are more in alignment with what the services that need to be provided. So thank you so much.
Thank you. Take care. Thanks, everyone.
Bye-bye.